Hi everyone, so my name is Suzanne, I'm one of the ACCS CT3 doctors and I'm going to be doing a little journal club today. So I thought we'd start just by discussing two cases, one of which is based on a real case that happened to me and Matt at a not to be mentioned period of time ago at a not to be mentioned hospital, which we've anonymised, and one which is hypothetical, and then go into talking about a paper. So the first case, so this is a 65-year-old man. You get an anaesthetic emergency call down to resus. Previously fit and well, had a history of some cough and fever, found by his family to be aggressive and confused, and brought in via ambulance 999. So when you get there, he is tachycardic, but an okay-ish blood pressure. However, he's in respiratory distress, not tolerating oxygen, and with very low sats, and he has IV access in situ. So that's the first kind of case to think about, and start thinking about what you're worried about and where you think this case might be going and what the issues might be. And then the second case, so a gentleman in his 50s with a suspected upper limb arterial injury, and a tourniquet in place, who has been brought into your district general hospital ED to make safe for transfer, because the ambulance crew don't think he's safe to take to the major trauma centre. He's aggressive, confused, attempting to remove his tourniquet. So when you go and see him, super aggressive, tourniquet on his left arm, not permitting obs, not tolerating IV access. So these two cases, obviously, they're very different, but they're both sort of heading vaguely in the same direction. So where do you think they're going? What are you starting to think about? And what are the potential problems with the plan in your head? Kind of talk to me. So the first case, so a chap who's possibly got pneumonia, very, very low sats, not tolerating anything. Where do you think we might be heading? What are you thinking?
They're both aggressive and unmanageable, aren't they? And
yeah.
For their own sort of safety and and to tolerate treatment, they need to be, the airway needs to be securely sedated.
Yeah. So these are people who are probably going to need some support for their airway. So options and issues. So both of these patients might actually end up requiring intubation, but they're going to be difficult to optimise for different reasons, but they're both going to be difficult to optimise. So you're not going to be able to get adequate pre-oxygenation. There's a risk of desaturation, and they're both at risk of aspiration. So if you make the decision to intubate, how are you going to do it? So possibly an RSI, but you can't optimise them. So you're going to have to think about minimising apnea. So how might you do that? Maybe a choice of neuromuscular blocker, so sucks rather than rock, or just making the decision to bag mask ventilate and to do a kind of modified RSI. But the paper that I'm going to talk about today, and what I sort of wanted to introduce as another alternative option, is something called a delayed sequence intubation, or a DSI. So that's the paper that we're going to talk about, delayed sequence intubation. So what is it, first of all, before we start to go in to talk about the paper? So it's not a new idea. It's been around in some form for quite a few years, but it was sort of labelled as such by a ED physician called Scott Weingart, who works out of New York, in 2011. Essentially, it's procedural sedation, where the procedure is optimising the patient for intubation. So whether that be pre-oxygenation, or positioning, applying some monitoring, emptying the GI tract with an NG tube, and actually just calming down the situation and taking it down from being something with a screaming, aggressive patient where no one's really in control, to a situation where you can have a proper team brief and do things in a safe and systematic way. So you kind of disrupt the sequence slightly of a normal RSI. So you start by sedating the patient, and you want to aim to maintain spontaneous ventilation and airway reflexes. So kind of the ideal agent for this is ketamine. And you start with a slow IV dose of 1 milligrams per kilogram, wait 10 to 15 seconds, and then give further aliquots of 0.5 mg per kg, titrating to effect. Then you optimise and pre-oxygenate the patient, and then you anaesthetise them. And so the study that we're going to look at is from 2015 in the Annals of Emergency Medicine by Scott Weingart and colleagues. And the clinical question that they had was, so in patients who require emergency intubation and who are not tolerating pre-oxygenation, does the use of their DSI protocol improve their saturations? So that's the first thing to think about, is actually they were looking at improving saturations as their outcome, not necessarily anything more clinical or pre-oxygenation. So it was a prospective observational case series. It was a non-randomized convenient sample, and it wasn't blinded. It was across 3 centres, so 2 in the USA and 1 in Denmark, and they were all level 1 trauma centres or quaternary referral centres. They were in either ED or ICU immediately post-ED admission, and the study was over a period of about 2 years in the early 2010s. So they included adults, they must be spontaneously breathing, they required emergency intubation, there were no predicted difficult airways, and they must have been patients who did not tolerate pre-oxygenation despite maximal conventional attempts. So their definition of not tolerating pre-oxygenation was either not verbally consenting to have the oxygen mask on, so saying no, take it off, or physically removing the mask, and maximal conventional attempts. So they said they had 3 attempts to assist the patient, either to talking to them to calm them down, helping them to hold the mask themselves, things like that. Yeah. So the intervention was very protocolized. They used ketamine at the initial dose that along the protocol that I described earlier. So the initial dose of 1 mg per kg IV as a slow bolus, and that was really key, not fast, slow, followed by 0.5 milligrams per kilogram until they were dissociated, which was a clinical judgment. They then were placed greater than 30 degrees head up, and their pre-oxygenation was with a non-rebreathe mask and nasal cannula as the first line. And then what they did was, if they had SATs of less than 95%, they used CPAP to pre-oxygenate their patients. So 39 had CPAP and 23 did not, just had the non-rebreathe mask and nasal cannula. So that's slightly different to how we would approach it, pre-oxygenation in the UK with a water circuit, say. And then after 3 minutes, they were paralysed with either socks or rock at the clinician's preference, and then intubated. So there was no true control group. The comparison was was for the patient individually themselves. So they looked at the patient's SATs prior and post the pre-oxygenation with ketamine. So Scott Weingart described it as a self-control, but there was no true control group who had just normal, usual care. And this is just a flow chart describing what we've talked about, the process of DSI. So dissociation, then pre-oxygenation, paralysing, apneic oxygenation, and intubation. So there were 64 eligible patients. 2 were excluded because they couldn't get a post-DSI SATs reading. Now they did a gas, they did an arterial gas and confirmed that the SaO2 was 100%. So it wasn't that they had unrecordable oxygen saturations, it was judged to be an equipment failure. So 62 patients received the DSI, 23 via a non-rebreathe mask and 39 via CPAP. And then most were intubated, apart from 2 actually who were pre-oxygenated with the CPAP. And both of those patients were asthmatics, who they judged to have made a slight improvement with ketamine. So these are the characteristics. So they were a mean age of 54. The range was between 18 and 79, and they were mostly men. About 2/3 were men. Mostly in ED. 7 were intubated in critical care. 55 were intubated in the emergency department. And the conditions requiring intubation. So most had pneumonia. Some had asthma. 7. There were a couple who had other interesting things like anaphylaxis and encephalopathy because of sepsis or hepatic dysfunction, and upper GI bleeds, 1 cardiogenic shock and 1 trauma patient. And the mean ketamine dose that was given was 112 milligrams. So for the patients who their weight was available, which was 43 of the 62, that was a dose overall of 1.4 milligrams per kilogram. So their primary outcome, as I said, was the difference in saturations after their pre-oxygenation protocol, with standard attempts, so at the beginning, and after ketamine DSI. So if you look at that graph, the blue dots are the patients just with the standard attempts, and then the red dot, which is joined by the line, represents that same individual patient post the DSI protocol. So there was an increase in their saturations from an average of about 88.9% to 98%, with some good confidence intervals. And the secondary outcomes, so they did a subgroup analysis looking at patients who had initially very low saturations, and they all increased their sats. No patients had what they defined as significant complications, so significant apnea pre-delivery of muscle relaxant, emesis, cardiac arrest or death. But as I said, 2 patients did actually improve after being given ketamine to the point that they didn't require intubation. But they were both asthmatic patients, and ketamine is we know that it's a bronchodilator. And very, very importantly, it's not a recommendation to. The study was very, very careful the author was very careful to say that he doesn't recommend using DSI as a potential technique for avoiding intubation in acute severe asthma. It was more just a something that was commented on. So they concluded that DSI could safely allow the provision of pre-oxygenation to patients who didn't tolerate it via traditional methods. But obviously their assessment of pre-oxygenation was saturations improving. So evidence for DSI then, so just looking at the strengths and the weaknesses of the study, it was a multi-centre prospective study, and they used a standardised protocol, so it's easy to follow, but it was quite small, so only 3 centres with only 62 patients. It wasn't blinded, there was no control group, and it was a convenience sample, which means it's prone to selection bias. And also importantly, I think for us as all relatively junior anaesthetists and airway managers, the DSI protocol was performed by clinicians who have very extensive experience in the use of ketamine sedation. And Weingart and his colleagues, they're extremely pro ketamine. A lot of the literature that is used as evidence for the use of ketamine has his name on it or the name of one of his colleagues. So I think that's just worth bearing in mind, is actually this is something that does appear to work very well in experienced hands. So just a few comments, I thought, to sort of start off the discussion. They used SATs as their measure of pre-oxygenation, and that's not what we use. We would use the difference between inspired and end-tidal O2. There are some other negative side effects of ketamine that you need to think about, and actually, are you just going to make a bad situation worse? So ketamine's emetogenic, but is this more likely to be a post-emergence phenomenon, and actually could you just manage that with ondansetron? Is that more likely to be a problem if you end up not intubating, say in the case of those 2 asthmatic patients who you put on NIV? Hypersalivation and also the SNS hyperstimulation of ketamine. So the author did mention SNS hyperstimulation and said actually in his experience, these patients who do present with the kind of sympathetic overstimulation, when you sedate them, rather than the SNS kind of hyperactivity that you might expect to see with ketamine, what you get is just a calming of the whole situation, and their numbers improve. But again, that's just in his experience. Is ketamine the best agent, or is there a role for some other sedative agents if you're going to do this? So ketamine's good down in ED because it's got a wide therapeutic range and it's got quite a large margin of safety in the critically unwell patients. So it is a good choice. This is probably less the case for propofol. I'm not sure that I would fancy doing this with propofol. But is there a role for other agents like alpha-2 agonists, so dexmedetomidine, actually maybe, but they are slower to act, so you couldn't do it as quickly, or perhaps it would be less easy to titrate to effect. And then just think about the other airway problems that you might be getting with ketamine. So does ketamine actually cause apnea? So the biggest systematic review looking at ketamine for sedation suggests not significantly. That was again a paper from 2008 produced from the same unit in Mount Sinai in New York. I think Ruben Strayer and colleagues. But what you do see, according to them, is actually a kind of short period of apnea lasting between 15 and 30 seconds. Is that long enough to be significant in somebody who is already decompensated and already has low oxygen saturations, perhaps? But they were very clear in the protocol that the way you give ketamine for this is not as a bolus, it is slow. And actually that is something which helps you to avoid the episodic apnea. And also just being aware of the risk for the laryngospasm. So I think the takeaway for this is if you're going to do it, excellent. but whenever you're doing anything like this, in your head, you should also be preparing to do an RSI.
Yeah.
So yeah, just some references. There's a good podcast actually. EM Crit is the podcast that Scott Weingart does, and he's got an episode where he talks about this, which is episode 137. And then there's just a couple of other references there.
Is he an EM consultant? Or
he's an EM attending, and he's also an intensivist as well.
Okay.
He's the man, yeah. He's very.
I've seen him do something similar-ish to this at the BRI, but it was one of the pre-hospital care consultants that did it. Similar to your second case, guy with a massive machete wound, sanguinated in the back of a police car, very, very agitated. So I can't remember what he gave him IM. I think it was ketamine IM, knocked him out, dragged him in, RSI'd in the recess room. But there was no way you were going to get him, you couldn't have got IV access.
No. So this is actually what we did in that case. That second case was the real case that we had down in ED, and the ICU consultant was there, and that's what we ended up doing, was giving IM ketamine. So I don't know, you call it maybe a modified DSI. But we gave IM ketamine, so procedural sedation to allow us to establish IV access, apply monitoring, pre-oxygenate, to optimise the patient for intubation and to make it all safer.
Out of interest, what dose of IM ketamine? Because you kind of have to commit a bit more.
I know, we were discussing this last night, and I'll be darned if I can remember, because all I saw was the ICU consultant and a dart of ketamine.
Yeah, this is like door open, door shut.
Yeah.
Wait for it to take place.
Then another dart.
And then another dart of ketamine. Yeah. But it worked quite nicely, actually.
And how long did it take to surface?
Honestly, things started to calm down after about 30-40 seconds, and then sort of 2-3 minutes we were able to move him. I think.
It's almost like the dart also seemed to.
Yeah.
Like the shock of the dart was like, oh.
Oh, what's happening?
And then,
is that fair, Matt? What do you remember it differently?
None remember it very similarly. I think it'll also be one of the, like, when you have those cases where they're, so I think the wear-off time for ketamine is fairly quick as well. We're talking a few minutes for a patient to be back to sort of their previous GCS. Am I right in saying that?
I wouldn't say
a sedative dose.
So it's definitely the half-life is definitely shorter than propofol. Like the elimination half-life is definitely shorter than propofol for ketamine.
You are the person that will know.
I can tell you the clearance of ketamine.
Well, I think there'll be quite a lot of cases like, even like say so let's say I had someone who's very agitated coming in for ECT, who's not going to let you get anywhere near them. Actually, you're not going to be able to sort of sedate them to say propofol. You could use say this sort of approach with ketamine and the IM approach. If you're in your anaesthetic room, I can see that potentially becoming a role, or your patient who's just very agitated.
so the BNS says this is for induction for short procedures. I am 6.5 to 13 milligrams per kilo.
That's 40.
Did you manage to get hold of the concentrated ketamine?
It was 50 per mil.
Yeah.
The ketamine we have downstairs is 50 per mil.
I thought it was 3 to 5 milligrams per kilo.
So this is for
It's high. I know it's higher than the IV dose.
Yeah.
Definitely.
But a dose of 10 milligrams per kilo usually produces 12 to 25 minutes of surgical anaesthesia. So I mean,
Surgical anaesthesia. Yeah.
half that.
Yeah. I think that was my sort of unofficial takeaway from this paper is, I guess, like 2 things for me. If you're going to do it, excellent, but prepare to do an RSI in your head. Like in your head, you're also doing an RSI, because then you won't get caught short. And just carefully titrating it. Not whacking in a mg per kilogram. Gently pushing it in and then watching and then giving more if you need.
Are we talking about sort of a 2-agent anaesthetic then here? So are you giving some opiate with your muscle relaxant, or are you just waiting till they're pre-oxygenated? If they've still got enough ketamine on board, sucks all what goes in and then the tube goes down.
So just essentially, yes, I would also give opioid, but the only difference is the order of events. If you like, you're giving the induction, you're giving part of the induction agent prior. And actually, they were saying you don't necessarily need to give more induction agent. If you can achieve spontaneous ventilation with protected airway reflexes, but at a dose which is sufficient for anaesthesia.
Had your chap taken some street drugs?
Don't know. No history.
Because this chap had definitely taken.
I mean, there were elements of his behaviour that were suggestive of something, definitely, but we didn't really have a history. And then we stopped him being able to give us a history.
But then there were access issues and a lot of other stuff at the same time.
I wouldn't be surprised. Cool. I think I might end the recording there then, Kartik.
Lovely, absolutely. Thanks, Susie.
Thanks.
Stop recording.